That's all.
I don't have any Netflix.
That's good.
Huh?
That's good.
No, yeah, because I know my weaknesses, basically. If I start using Netflix, then I get addicted. Because every day is a Sunday for me now.
Yes, yes. We are streaming this live on YouTube also. Huh? It will be seen.
Is it?
Yeah. It will be seen on YouTube.
Anyway. Yeah, I was more nervous about this than about the lecture.
It is actually it's very easy. The reason these Zoom people have become so successful is that whole interface is so simple.
But people were telling me, Halia was reading about it, and she was telling me, okay, some people are a little worried about the security of Zoom.
Yeah, but that
I
is
said, but for us, what is the security? These
that,
are only slides, these are only slides, and people are asking us questions.
yes.
That's the question.
So that security thing comes for these
I
big
think for organizations and
yeah,
when they are sending
organizations which have
important data.
official meetings and things like that, there it's okay. How does it matter to us?
I've got all the multiple choice questions in front of me, and at the end of it, I can read them. Okay.
Yeah. Yes.
If at all, or otherwise, let people ask me questions.
Okay.
Because this will be a little.
I think we'll have questions.
Okay. I hope I can answer them. Some people ask questions only to get their voices heard.
No, here there's no voice heard. It is going to be they have to type the question. So we will not.
They allow their presence to be known. How did the Parkinson's thing go yesterday?
Dr. Singhal's?
Yeah.
Went well, very well. I couldn't attend, but the feedback was very good.
Who gets the feedback?
Who gets means?
You get the feedback, or
no, people were discussing in that man WhatsApp group and other groups, no?
I'm not in those groups anyway. I'm in no WhatsApp group. I don't like to be in any WhatsApp group.
Okay. So, sir, next talk for you instead of the CPC is art and neurology.
You want me to talk of that perception of vision?
I don't know. Shirsa told me you have a very good talk called art and neurology.
Yeah, that's perception of vision.
Okay.
A twist in the tail.
Do that, sir. Do that next.
Okay. Or I can do pupils.
Pupils later. This art thing will be more interesting.
Yeah, it's a very light talk. It's not a very heavy talk.
So that's nice. So, in fact, there's one. I am keeping a thing on. There is one person called Anil Seth. He's a neuroscientist who talks about how your brain hallucinates your reality. So his talk is there.
And I should be getting a lot of hallucinations.
So this is he's got a very good TED talk on your hallucinates your reality. It's a wonderful talk. And luckily he agreed to give us a talk. So I think it's on the 20th. I'm not sure the date, but I'll let you know. Because it will be like if your thing is about perception, then this is all about visual perception. Visual perception is a best guess made by the brain. There is no such
Who told you about this talk of mine?
Ashok Sirsat.
Ashok Sirsat. Yeah. I'll tell you, I was supposed to address the Maharashtra Ophthalmic Society on perception of vision. And I was bored to my gills trying to get that lecture in place. And I said, I must take a little time off. Okay. At that stage, my son had bought a book on Salvador Dali.
Oh.
and I started turning the pages of his paintings and whatnot. And that was the beginning of how I totally changed that lecture.
This one,
No?
have you heard Ramachandran, V.S. Ramachandran on?
Yes, yes, yes. On Indian art,
Yes.
I have his book Phantoms in Your
Yeah.
Brain.
Wonderful book. I was going to keep his talk, but he's got Parkinson's now. I don't know whether he'll be able to give
Oh,
Ramachandran.
he did a very interesting one with John Cleese on the BBC.
Okay.
And he said all these cameras which look at visual recognition, face recognition, and they use interpupillary distances.
Oh.
So he made John Cleese dress up in various disguises. And the camera, John Cleese, John Cleese, John Cleese.
Oh.
Then he told John Cleese, you please wear a pair of dark glasses with that reflectile surface where you cannot see the pupils.
Delicate.
And as John Cleese, he wore those dark glasses.
When was this? When was this? This must be recent.
No, quite some time ago. I saw it actually in Australia.
Okay.
Lovely one, where he explains all those phantom limb type of things.
Yeah.
Chal, I think it's 11 o'clock.
Yeah, we are going to have 200, I think, by the time you start. It's 168 now. So let's start. Let me introduce Dr. Katrak. He has kindly agreed to give us some talks. The first talk is Unexplained Visual Loss. Dr. Katrak is, of course, everybody knows. He has been the director, his Department of Neurology and in Jaslok, and of course, a professor in JJ Hospital and Grand Medical. So over to you, sir.
Thank you, Sudhir. Now, good morning, everybody. In the first slide, you see my title is Unexplained Visual Loss. I would like to explain this title a little bit. When a patient presents to you with diplopia, and you look at the patient, and you realize that the patient has a divergent squint or a convergent squint and a ptosis, you know in which direction you're going. You know that you're dealing with an ophthalmoplegia. However, one of the most vexing problems in neurology is when a patient complains of visual loss, and on observation of the eyes, you do not see any abnormality. So at that point in time, it is really an unexplained visual loss. It is tempting at that stage to embark on expensive laboratory investigations or neuroimaging. But the purpose of this talk is to give you an algorithm of neuro-ophthalmic examination, which will lead you invariably or in the majority of cases into the right diagnosis. These neuro-ophthalmic examinations are relatively simple and can be performed at the bedside. So when a patient complains of visual loss, it is basically two situations. The patient has a subnormal acuity, but on examination of the eyes, everything appears to be normal. Or the patient has normal acuity, can see very well, but still has symptoms of visual loss. The first step in this algorithm is to first differentiate optical problems from neuroretinal problems. And optical problems most of the times are refractory errors, but you can get abnormalities of the media like tear films, corneal opacity, lens problems, vitreous problems. The second part is neuroretinal problems, and they involve the complete optic pathways right from the retina to the visual cortex. Now, each area or each junction, that is retina, optic nerve, optic chiasma, has its own classical findings on neuro-ophthalmic examination. And that is the purpose of taking you on a pathway, on a trip along the neuroretinal pathways. Now, the first logical step is you do a pinhole test. And if the acuity improves, it's an optical problem. So it is out of your purview. However, if the acuity of vision does not improve, it is a neuroretinal problem. And the next step is to do a swinging torchlight test. You can also do color saturation or brightness comparisons. These are for very subtle retinal involvement. But from a neurological point of view, you do the swinging flashlight test. Now, the swinging flashlight test is performed very simply, as you all know, that you shine a torch in one eye, and through the direct light reflex, the pupil constricts. But the opposite pupil also constricts because of the consensual light reflex. Therefore, when you swing the torchlight to the opposite eye also the pupil constricts. Now, if in this diagram, if the left eye is affected, you do the direct light reflex, you flash the light in the right eye, and the right pupil constricts, and through the consensual light reflex, the left pupil also constricts. But because there's an involvement of the afferent pathway, when you swing the torchlight to the opposite side, the direct light reflex is absent, and therefore the pupil dilates. This is known as a relative afferent pupillary defect. It is a very simple test. It's very reliable, it's very sensitive, and it's ideally suited for our Indian eyes, in which we have dark irises, and therefore it is very difficult to look at the consensual light reflex when done in the conventional method, which is described in your textbooks. Now, a positive relative afferent pupillary defect invariably denotes a unilateral optic nerve disease. It can also occur with extensive retinal disease and occasionally with asymmetrical chiasmal disease. But by far and large, in clinical neurology, it reflects a unilateral optic nerve disease. There are a few precautions in doing this test. It should be performed in a dim illumination and with distal fixation. That is to see to it that the pupils are maximally dilated in the prevailing conditions. Secondly, to avoid convergence and fixation, near fixation, don't stand directly in front of the patient and shine the torchlight from an angle and not directly in front of the patient. The best way to do it is to shine the torch slightly from the outer side and slightly below so that the patient's fixation is not involved. Shine the torch in the eye and then take a U shape and shine the torch in the other eye. Please do it at a frequency of about 1 to 2 seconds. If you keep the torch longer in one eye, you may get the hippus and you may get a false dilatation of the pupil. All right, so this is a very sensitive test. Therefore, let's go to our algorithm. You do the swinging flashlight test and you get a visual loss with an afferent pupillary defect or a visual loss without an afferent pupillary defect. And we'll deal with that part later. Now, once you get a visual loss with an afferent pupillary defect, therefore the next step is do a visual field charting. Now, this can be done at the bedside. And I will teach you how to do it at the bedside in a very succinct manner. But the visual field charting will give rise to two types of defects. Either you have a nerve fiber bundle type of defect, which indicates a lesion of the retinal nerve or the optic nerve, retina or the optic nerve, or you get a hemianopic defects. So at present, let's go to the nerve fiber bundle type of defect. And they are mainly four. They are central or centrocecal scotoma. This indicates an involvement of the maculo-papillary bundle. And therefore, it is the main central site of vision. You have an altitudinal scotoma, which is due to involvement of either the posterior ciliary arteries or the retinal artery, and its involvement of the upper or the lower branch, so that you get a defect which has a clear demarcation at the equatorial region of the field of vision. The next bundle type of defect is the arcuate scotoma. Arcuate means a comma, so it's a comma-shaped scotoma, and it is in fact involvement of some of the branches of the retinal artery, and therefore it is very much like a focal altitudinal scotoma. However, an arcuate scotoma can also occur in glaucoma. And the last defect is a concentric-like defect. This is a non-specific nerve fiber and can occur after many things: involvement of the retina, periphery of the retina, or most likely for the neurologist, it is usually seen after post-papillomatous optic atrophy. Now, how do you do these tests? The simple way of doing it is you stand in front of the patient, ask him to close one eye and look at your face and look at your hands. Ask him whether my face is clear or whether my hands are clear. And if you have a central cecal scotoma, the patient will tell you that your face appears fuzzy, whereas your hands are quite clear. When you're dealing with a hemianopic defect, please see to it that the nasal part, suppose you're examining the right eye, then you keep your right hand closer to your ear than the left hand, which will reflect the temporal field of vision. Okay? So you look at this, and it's a very simple way of detecting a nerve fiber bundle type of defect. If you have an altitudinal, the patient will tell you that the lower part is more blurry than the upper part. If you have a hemianopic defect, you will see to it that one side is more blurry than the other. Therefore, you have an unexplained visual loss with an afferent pupillary defect and a nerve bundle type of field of vision defect. Now, for the purpose of this lecture, I will strictly restrict myself to central cecal or scotoma, or a total visual loss in one eye. And there the lesions are in the retinal nerve fiber layers or in the optic nerve. For the purpose of this lecture, read it as optic nerve involvement. Please remember that 97% of these lesions are non-compressive. Therefore, in the older days, we used to advocate that you do not require neuroimaging if you get these combination of this. But nowadays, neuroimaging is necessary because you want to prognosticate for certain reasons. Now, many of these lesions may be congenital, hereditary, inflammatory, ischemic, and traumatic. Note that I've omitted demyelinating lesions for the time being. And now I will concentrate on these ischemic regions where the response to therapy is usually poor. Now, the most important is an ocular stroke. It's a central retinal artery occlusion. The central retinal artery supplies the bipolar layers of the retina up to the bipolar layers of the retina. It is narrowest at the level of the lamina cribrosa. That is the optic disc, the central part of the optic disc, and therefore that is the site at which it is really obstructed more often than not. It produces sudden blindness without pain. And ophthalmic findings are that of segmentation, narrowing of the arterioles, and a cherry red spot. Now, please remember this cherry red spot is a Western Caucasian finding. In our Indian pupils, because of our melanin pigmentation, it is usually brownish. There is, in the acute phase, there will be pallor of the retina, but the disc may appear normal. In the chronic phase, the retinal pallor may disappear and it may result in an optic atrophy. Now, What are the causes of it? It may be embolic, it may be atheroma with a superadded thrombus, it may be due to vasculitis like in giant cell arteritis, it may be a simple angiospasm, or it may be secondary to trauma, which involves a fracture of the orbital fissure. Now, and I'd like to explain, this is a patient who came to us nearly 1 month after an acute optic atrophy and blindness. And you can see that the disc is pale. Here you can see that there is segmentation of the RBC column. And then you see ghosts of blood vessels. You can see that here also, segmentation and ghost of blood vessels. And the macula is atrophied. And there is scarring. This was seen in a lady who had bilateral acute optic atrophy secondary to retroviral disease. Now, we come to amaurosis fugax. If central retinal artery occlusion is a stroke, then amaurosis fugax are TIAs. They can be embolic in source, or they may be from a plaque from the internal carotid artery. The characteristic that the attacks are acute, they are very brief, lasting for mere seconds. Normally, we say that TIAs do not last for seconds. The exception to the rule of a TIA lasting for seconds is amaurosis fugax. And they can be multiple. They can be 25, 30 in a day. They are due to cholesterol crystal or tetrafibrin emboli. Amaurosis fugax is basically not a good predictor of strokes because they are multiple in nature and they are very brief, but they imply that you may be heading for a central retinal artery occlusion. And in a central retinal artery occlusion, the prognosis for vision and for life also are not very good because, as you remember, the retinal artery is a branch of the ophthalmic artery, which in turn is a branch of the internal carotid artery. Therefore, you can expect a major stroke. Now, having come up to this point, on occasions, a careful fundoscopy may show you changes in the retina which reflect a condition, a systemic disorder, which predominantly involves the central nervous system. And in this respect, you have the phacomatoses. You have neurofibromatosis, tuberous sclerosis, angiomatosis of the retina and CNS, Sturge-Weber, and many, many conditions. Time does not permit me to go through all these conditions, but let me give you an example of angiomatosis of the retina and the CNS. Now, this was a patient who presented with blindness in one eye, and we were looking at the fundus, and if you look at the fundus, you will see that this vein is markedly tortuous and slightly thicker than the other veins. We followed it up to the periphery, and it resulted in a hemangioblastoma. This is the montage of the right eye, and it shows that he had a hemangioblastoma in that eye. This is the same patient's CT scan, which showed a cerebellar hemangioblastoma. So that you can pick up certain systemic conditions by a careful look at the fundus. Now, this is a patient who presented with blindness in one eye. And if you look at it, there are multiple choroid tubercles. So it is very easy to say that the cause of the blindness is basal arachnoiditis or optico-chiasmal arachnoiditis, as it is known. This is a rather peculiar condition. If you know about this condition, you can make a spot diagnosis. This is the peripheral retinal picture. And you see neovascularization. You can see perivenous sheathing with obliteration and multiple scarrings. Okay, you can see the scarring here, and you can see the perivenous sheathing and neovascularization. This is a case of Eales disease. And my mentor, Dr. B.S. Singer, had described 18 patients with Eales disease and a myelopathy, usually with sphincter involvement and retinal involvement. Now, if you know of this condition, many of these cases you can diagnose in the outpatients department. If you look carefully at the retina, at the periphery of the retina, in a young male who presents to you with a spastic paraparesis or spastic paraplegia. And all of you know about this slide. I've shown it very often. This is cysticercosis with the lava floating in the vitreous and producing blindness in one eye. That is neurocysticercosis. And many of you are aware, close to lunchtime, I should say, this is cheese and tomato exudates of CMV retinitis. Okay, not very appetizing for the patient. Actually, this is most commonly seen in opportunistic infections in HIV disorders. However, you can also see it sometimes in non-retroviral AIDS, and this was actually a case of renal transplantation who was on immunosuppressant therapy. Now, we come to the main term, demyelinating optic neuritis. As you know, it affects young women more than men. I don't have to tell you that. The point that I would like to reiterate is that in adults, it is usually a unilateral optic neuritis, whereas in children below the age of 40, it may be bilateral. The risk of developing MS is about 40% in the West. In India, no data, epidemiological data is available, but it is believed to be less than in the West. However, the risk of developing MS, you can have an MRI, which is very helpful in making a prognosis. The points are that if you have only one white matter hyperintense lesion, the risk of developing MS is negligible. However, if you have 3 or more lesions in the appropriate places, meaning the periventricular area, corpus callosum, dorsal fingers, or in the cerebellum, the risk can be as high as 40 to 60%. The loss of vision is rapid in optic neuritis over 2 to 5 days, and it is associated with pain, which may be retroorbital, movement of the eyeball, or on movement of the eyeball. So the patient complains of pain in the eye, around the eye, and on movement of the eyeball. And this pain may precede the optic atrophy by 24 to 48 hours. It lasts for 10 to 14 days, and it is very responsive to treatment. The causes you all know. We are essentially dealing with demyelination. Now, there are two terms. Retrobulbar neuritis, which indicates that it is a posterior lesion. Posterior, that means behind the globe of the eye. And it is not seen on fundoscopy. If it is, that is the condition. I put an asterisk there because this is the condition in which the positive swinging torchlight test is very, very useful. You know that there is an optic nerve problem, but the fundoscopy does not show any optic atrophy in the acute stage. So this is the usefulness of the swinging torchlight test. In small percentage of cases, about 38, it involves the anterior part of the optic nerve, the disc, and it's an anterior lesion with a swelling of the optic disc and exudates. Now, how do you differentiate it from papilledema, which is the closest differential diagnosis? It's a very simple idiom. If the drop in the acuity of vision is very severe and the swelling of the disc is mild, it is papillitis. If it is severe swelling of the disc with a marginal drop in the acuity of vision, it is papillary. It is as simple as that. The other differential diagnoses are optic nerve drusense, but in optic nerve drusense and the other conditions, the acuity of vision is very rarely affected, particularly in optic nerve drusense. But I'd like to show you a case of mine. How do you diagnose optic nerve drusense on neuroimaging? And if you look at the upper left-hand picture, you will see that where the optic nerves meet up with the globe, there is a little bit of hyperdensity. That is the calcium deposits, and which is very well seen in this on the right top slide, and on the bottom it can be seen in the lateral cuts. So this is very easy to demarcate, but in drusense you do not get any drop in the acuity of vision. The investigations you all know, and I won't dwell on them: oligoclonal bands, NMO spectrum disorders, visual evoked potentials, and MRI. Treatment, all of you know. Prognosis is improvement in 75% of the cases in 1 to 4 weeks. Now we go to a swinging torchlight test, which is positive. There's visual loss with an afferent pupillary defect. You have done a visual field charting, and you have a hemianopic defect. Now, a hemianopic defect, there is a clear-cut vertical demarcation for the abnormal and the normal side. Therefore, it cannot be mistaken for any nerve bundle type of defect on the field of vision. Now, what are the lesions? The lesions are at the level of junction of the optic nerve with the chiasma, or some of the lesions of the optic chiasma. Now, the most specific lesion is what is known as a junctional scotoma. In this diagram, if you see, the lesion is at this level. The two lines indicate the lesion. And you see, you must note that the inferior nasal fibers, as they cross the optic chiasma, they cross anteriorly and below. Whereas the upper nasal fibers cross posteriorly and dorsally. A second anatomical point is that these nasal fibers, inferior nasal fibers, they loop into the optic nerve, producing what is known as a genu or a knee. And then they go into the optic tract. Therefore, if there is a lesion at this point, and they are usually compressive, they will involve the optic nerve, and in the early stages, you may get a centrocecal scotoma. In the late stages, you will get a total optic atrophy. But if you look at the opposite field of vision, you get an upper quadrantic temporal quadrant enopia. So upper temporal quadrant enopia. Therefore, the idiom is that if you have a progressive optic visual loss, indicative of an optic nerve involvement, there are two things that you must invariably do. One is check the sense of smell, and if there's ipsilateral anosmia, you can make a spot diagnosis of an olfactory groove meningioma. Check the opposite upper temporal quadrant enopia, and if you detect that it is a junctional scotoma and the localization is at the junction of the optic nerve with the chiasma. Now, this is one patient who presented to us nearly 2 months after the onset of his symptoms. And the onset of the symptoms were retrobulbar neuritis, diagnosed as retrobulbar neuritis. And the patient had received several retrobulbar injections by ophthalmologists. Nobody had bothered to check the opposite temporal quadrant. And we picked that up and we did the imaging, and there you have the junctional scotoma was missed, and you have a pituitary adenoma. Now, there are other features of the chiasma vis-a-vis the pituitary gland. By far and large, the normal position of the chiasma is just above the pituitary gland. Okay, but in about 12 to 14%, it may be a prefix chiasma, that is anterior to the pituitary fossa, in which event a pituitary tumor will involve the optic tract and not the optic nerve. Whereas in rarities, there is a postfix chiasma. Here the dot is wrong, the dot should have been here, but it is behind the pituitary fossa, and therefore any pituitary tumor will produce an optic compression, optic nerve compression. And this I have already told you that the lower nasal fibers are ventrally placed and more anterior, whereas the upper nasal fibers are dorsally and more posteriorly placed in the optic chiasm. And these are just to show you the anatomical lay. This is a normal pituitary gland, and you can see the optic nerve and optic chiasma. This is a pituitary, sorry. This is a pituitary adenoma, and you can see the optic chiasma above the pituitary adenoma. Now, this is a cartoon which shows you the various tumors which produce compression of the chiasma. And on the left-hand side, you have sphenoidal bridge meningiomas, olfactory groove meningiomas, and tuberculum swelling meningiomas. You can get an intracellular aneurysm from the bottom, chromophobe adenoma, as I mentioned, and chordomas coming from the clivus. And from the behind and from the above, you can get a craniopharyngioma. So that completes visual loss with an afferent pupillary defect. Now, you can get visual loss without an afferent pupillary defect. If that is so, the first step is to rule out amblyopia, which is bilateral blindness, and therefore falls under the purview of the ophthalmologist. But as a neurologist, you have to rule out macular disease. And for macular disease, you think in terms of Tay-Sachs disease, metachromatic leukodystrophy, Niemann-Pick disorder, and neuronal ceroid lipofuscinosis. Now, this is one of my patients with sialidosis, and you can see that he had macular degeneration, as shown here. And as I mentioned, it is not a cherry red spot, but it is a brownish discoloration of the macula, with macular edema surrounding it. Therefore, if you have ruled out amblyopia or macular disease, the next step is come to history and visual field charting. Okay, now in a history and visual field charting, you can get normal function, which is subacute optic nerve disease or cone rod dystrophy. Here it is either normal, it is either functional, or it is a subtle optic nerve disease or cone rod dystrophy, in which color vision will be affected. Therefore, the patients will tell you that they see the television screen as very highly bright, or not bright, but the colors appear faded. If it is a tunnel vision, then it is usually hysteria with malingering. So please take the optokinetic drum and try out the optokinetic reflex. If you get even a few beats of nystagmus, you have made your diagnosis of either hysteria or malingering. If you have bilateral optic nerve disease, then you will naturally not have a visual loss with an afferent pupillary defect. Bitemporal hemianopias I have already covered, and therefore now I come to homonymous hemianopia with post-chiasmatic lesions. Now this is the whole optic radiation, right from the optic tracts right down to the occipital cortex. And as you can see, it produces various types of homonymous defects. There are 3 points that I would like to make on this slide. That the lesions of the optic radiation, as far as we are concerned, are parenchymatous lesions, usually due to strokes or slow-growing neoplasms. Since they are parenchymatous, they are associated with neurological deficits. So they do not occur totally in isolation. Now, the point that I would like to reiterate is that they are usually an intrinsic pathology of the brain. I have very rarely seen, very rarely seen external compression producing a hemianopic defect, and that too about 2 cases of meningiomas, convexity meningiomas. I have never seen these type of defects with subdural hematomas. So I would like you all to stress that point. Now we'll go rapidly. This is a young child who had post-encephalitic involvement and bilateral cortical blindness because of occipital lobe atrophy. This is a lady who was brought by her husband complaining. Please remember that these CT scans are pretty old and the right side is on the right side. These scans were done in the mid or late 80s, and they have been part of my collection since then. So this lady had a left temporal field of vision defect, and she kept bumping into things on the left-hand side. And the ophthalmologist could not explain her findings because everything was normal when he examined her. And it was easy to pick up. She had bruising over the left shoulder, and therefore it was easy to pick up a right PCA infarct. However, associated with hemianopic defects, you can get disorders of higher cortical function with visual disturbances. And those are Alexia with or without agraphia and visual agnosias of various types. In the interest of time, I will deal with Alexia and prosopagnosia. What are the characteristics of Alexia with agraphia? It is usually because of left inferior parietal lobe lesion, which involves the angular gyrus. Because it involves the angular gyrus, there is agraphia. The speech is fluent. Wernicke's area is usually not involved. And there is intact comprehension. Reading, as is mentioned, Alexia is impaired. Writing, agraphia is impaired. And the associated findings with the non-dominant hemisphere may be a Gertzmann syndrome, but usually the right visual field defect is there. Now, this is one of my patients who had a left parieto-occipital tuberculoma, as you can see, and he had Alexia with agraphia. We had treated him with anti-tuberculous medication, and as the tuberculosis responded to treatment, his agraphia disappeared first, and subsequently Alexia also disappeared. However, the more intriguing syndrome is Alexia without agraphia. And I would like to read out the history of one of my patients whom I had seen mid-70s, 1970s, soon after I had passed my DM in neurology. And this Jesuit priest gave me the diagnosis in his very history. He mentioned, I have to lock myself up in my room when I write letters to Rome. If I am disturbed, I can't read what I have written. He gave me the answer, Alexia without agraphia. He could arrange playing cards in ascending order, but he could not identify each individual card if you showed it to him. He slowly progressed from Alexia without agraphia to Alexia with agraphia. And his neuroimaging, I think in those days we had only an angiogram. It showed a cystic glioma in the left parieto-occipital region. Now, this is to explain the thing. He had a right homonymous field of vision defect, and therefore all the visual information normally falls only on the right-hand side. This visual information on the right-hand side can compensate for reading abnormalities. However, this information has to be transferred to the opposite side and has to reach the angular gyrus. If it does not reach the angular gyrus, you get Alexia. And therefore, there's a lesion, associated lesion in the splenium of the corpus callosum. So it's a left occipital lobe lesion involving the splenium and can also involve the medial temporal lobe if it is due to a PCA infarct. The speech is normal. Comprehension is intact. Wernicke's area is not involved. Reading is impaired, as I mentioned. Writing is intact because the angular gyrus is still intact. Associated lesions are left homonymous hemianopia. Recent memory loss if it is due to medial temporal lobe involvement from a PCA infarct, and plus minus motor signs. And this is that patient's angiogram, which you can see the uplifting of the inferior temporal branch of the MCA. This patient subsequently was explored. The diagnosis was that of a grade 3 glioma, and subsequently the patient succumbed to his illness. The last case that I'd like to show you is a male 45 who presented in mid-October 1987. Acute onset of confusion on the way home. Could not recognize wife by face. Now, he was not drunk and therefore he was not pretending because he recognized his wife when she spoke. He could not identify the bed on which he was admitted, but he could draw a plan of our whole Ward 23. Findings: he had hypertensive and he had prosopagnosia, which is an inability, specific inability to recognize faces. Now let me tell you that this inability to recognize faces can occur in various types. For example, cases of prosopagnosia have been described in cow herdsmen who could not recognize their cows by their faces. Okay, so it is a very peculiar, and it's a very peculiar area. It is associated with visual or color agnosias, and it is usually associated with a right or left of hemianopia. And usually the lesion is in the left lower bank of the calcarean fissure, as it's shown, but most of the times the lesions are usually bilateral, as you can see in this patient here also. And this was the main lesion. Okay, so ladies and gentlemen, what appears to be an unexplained visual loss has a very logical explanation. And if you go through all these systematic neuro-ophthalmic examinations, you will reach a diagnosis invariably in a majority of cases. Expensive laboratory investigations and neuroimaging should be done, but to confirm your diagnosis and not because the patient has an unexplained visual loss. In these cases, I have shown you mainly CT scans. I haven't used very rarely MRIs. And the reason for that reminds me of an episode during my training days when I was doing a brain cutting session with Professor Darab Dastoor, who was the father of neuropathology. We had just completed a brain cutting session of a case of tubercle meningitis, And Dr. Dastoor felt that there were certain soft areas in the brain on the transverse sections suggestive of infarcts. And I asked him a stupid question stating, "Sir, will you be doing an electron microscopy on this case?" And he held my forearm very tightly and he gave me a piece of advice which sticks with me throughout the years. He told me, "Sarosh, remember that a low power microscope and a high power brain is better than a high power microscope and a low power brain." Thank you very much for your attention. Sudhir?
Uh, Excellent talk. We'll have to work on increasing the power of the brain by keeping more talks like this. I'm going to ask a few questions. How common is altitudinal field defect in optic neuritis?
Optic neuritis, no. Optic neuritis, altitudinal field defects are not there. Unless it is part and parcel of a vascular problem.
Right.
And one, I have seen it very occasionally in a case of giant cell arthritis to begin with, because it was a branch block.
Yes.
And subsequently, it can occlude the whole vessel and then it becomes total blindness.
Usually the altitudinal is lower or the upper?
It can be either.
Okay.
The retinal artery is narrowest at the lamina cribrosa I mentioned. And therefore, if it's an embolic, it blocks it at that point, and therefore it does not result in an altitudinal scotoma. It usually results in a total central retinal. However, there have been atheromatous changes in one of the branches, and therefore you can get an altitudinal field defect. Arcuate scotoma is even rarer. Than an altitudinal field defect.
Okay. Arcuate scotoma usually would be glaucoma, no?
Correct. Ischemia or glaucoma, one of the two.
Okay. Now, theoretically, this question was by Anand Diwan from Nasik. Theoretically, optic neuritis probably can cause any pattern of field defect referred to the optic nerve. But as you said, most commonly altitudinal will be vascular and optic neuritis demyelinating will be central scotoma.
See, basically it depends at what stage the patient comes to you. Basically, if they come to you early, then it may be a central scotoma. If they come to you late and there is retrobulbar neuritis which reflects anteriorly in the optic disc which becomes pale, then I think it's blindness, total blindness. Okay.
What about centrocecal scotomas? Those are usually toxic or degenerative.
They can occur.
Can you get it in demyelinating?
I think they are very common in demyelinating also because they involve the maculopapillary bundle. That is for your central vision. Now, toxic amblyopia depends on the dose of the toxin. If the dose of the toxin is very mild, then you may get a central scotoma. If the dose is very, very much, then you'll get total blindness.
Often, I think people get confused with macular vision loss and optic nerve. I don't know if we use the Amsler grid and all those things.
Well, I think once you start using, you need that, then you have to go and refer the patient to an ophthalmologist. Normally, what happens here is that if you have a retrobulbar neuritis, the ophthalmologist has already seen the patient.
Yes.
You understand? He has found nothing abnormal.
No, the patient first go to the ophthalmologist anyway.
Yeah, and the ophthalmologist has found nothing abnormal to explain the visual loss.
Then he'll say.
And therefore, it's referred to the neurologist. So some time goes by.
Dr. Naveen He asked a question. He recently had a case of a 55-year-old man without any risk factors, acute onset painless loss of vision, both eyes, for the last 4 days. He was referred from a retina institute because the fundus was normal. The MRI was also normal, but VP was abnormal, both amplitude and latency. And MS NMO workup was negative. So he was treated with steroids and antiplatelets. Vision improved to HM from PL positive. What could be the diagnosis, he's asking?
Some form of vasculitis. See, it's very unusual to get a central retinal artery occlusion bilateral.
Yes. So antiplatelet, I mean, vascular seems less likely bilateral. But what about MOG? He has written NMO negative, but he's not done MOG. So it,
Well,
those
I
are,
think when you get bilateral, I think NMO spectrum disorders, MOG, all that come into the picture.
okay. Uh,
What about the MRI findings?
MRI was normal. MRI was normal.
Was a spine MRI done?
He's not written. Probably must be.
See, if a spine MRI was done and if you looked at the lower part of the spinal cord and if there was an abnormality there, then MOG would stand up much higher than any other.
Okay. Then Dr. Krishna asks how to evaluate optic disc elevation by fundoscopy.
Well, see, normally the disc is elevated above the retina. The way I do it is I follow the blood vessels. If the blood vessels are totally clear as they go over the lip of the optic disc, then it's only an optic disc elevation. Once you start getting papilledema, then the blood vessels as they go over the disc disappear into a crowd and then appear again.
Right.
Okay.
And you can, people also use the diopter of the fundus to see the focus and see how elevated, but it is difficult with our indirect ophthalmoscopy. You
Yeah.
need a direct ophthalmoscope for that.
No, another thing is that look at the lamina cribrosa. If you can see the crisscrossing fibers of the lamina cribrosa, then it is disc elevation.
Okay.
Because once you start getting papilledema, the crisscrossing fibers of the lamina cribrosa are slightly obliterated because of the edema of the disc.
Yes. Sometimes people come with a non-specific or minor vision symptom and the disc is swollen and it may be pseudopapilledema and you got to be careful in that
In
situation.
those contexts, I showed you the case of that Drusens.
Yes.
Now that boy also had migraine.
Yes.
And he was complaining of severe headaches, episodic headaches, and this was his fundal picture, looking like pseudopapilledema. So surprisingly, he was admitted 3 times in a very good neurosurgery department of a public hospital. And lumbar punctures were done and the CSF pressure was measured. And every time the CSF pressure was found to be normal.
Oh,
Although the diagnosis was idiopathic intracranial hypertension.
But I have seen patients other way around, where it is drusen, patient is migraine actually, and manometry is done, which is said to be elevated, done by a neurologist. So manometry can be fallacious. You have to be careful if the patient is not relaxed, is not proper posture. You may
That's why, Sudhir, I said a good neurosurgery department in a public hospital.
Yes.
But because he had 3 times, the pressure was only 110.
You must.
And he was brought to me by his cousin sister who happened to be an ophthalmologist. And because one of my students had showed me how to diagnose Drusens on the CT scan,
Yes.
Dr. Firoz Patel. And that is the CT scan that I showed you.
Yes.
I could make a spot diagnosis of Drusens.
Even B mode, this ultrasound is also very useful.
Can also, I think.
Okay, then if Dr. Sunny asks, if papilledema is rapidly progressive, how do you differentiate from papillitis on the basis of visual acuity?
Well, the visual acuity should be drastically down and the edema of the disc should be minimal. If the edema of the disc is progressively getting worse, is it getting worse pari passu with the acuity of vision? I've seen gross papilledema with hardly any drop in the acuity of vision. The drop in the acuity of vision should be proportionate, should be disproportionate to the swelling of the disc if it is papillitis. And you cannot wait. You cannot wait to keep the patient under observation.
Right.
You know, when you say
even perimetry pattern between papillitis and papilledema might tell you.
No, scotoma. You will get scotoma.
Yeah, and in papilledema there will be peripheral loss and enlarged.
Correct. And then constriction, peripheral constriction.
Okay, then we come to the next question. What is the role of VEP in visual pathway lesions? In brief.
It is useful. I use them very often just to confirm my clinical diagnosis. There's only one condition, and I didn't mention it. When I mentioned about pain on movement of the eyeball in optic neuritis, I must tell you this case of mine. She is a known case of MS. And she had a left eye optic atrophy. But this time she came and she was already on steroids and getting a little Cushingoid. She came to me with a history that I'm getting severe pain on movement of my right eyeball. And I can't move my right eyeball. There was no change in the acuity of vision in the right eye. But when we did a VEP, we found that there was a drop in the VEP in the right eye. And we increased the dose of steroids, did not help. Ultimately, we gave her rituximab with a resolution of the pain. But there was no drop in the acuity of vision on confrontation. It was only on the VEP that we found out that there was a pathology that was going on below the surface.
I have also seen patients who came first with pain in the eye and I thought it is psychogenic, and then later they develop loss of vision.
Usually they develop loss of vision after 24 to 48 hours. Okay. But this lady had gone on for quite some time.
Okay, Dr. Litti asks you how to differentiate higher cortical visual defect from functional blindness.
Cortical blindness
versus
higher function. Cortical blindness versus malingering or functional blindness.
No, cortical blindness versus a defect of higher function, higher cortical visual defect. Like
cortical blindness is a higher disorder. If it is blindness, it's blindness.
Yes.
Higher cortical functions will have a hemianopia.
No, not cortical blindness. It is higher cortical visual defect, which includes cortical blindness from functional blindness. Somebody who's functional versus a cortical lesion.
Usually they have a hemianopia, which a functional patient is not supposed to know. All these cases of Alexia with or without agraphia, prosopagnosia, they have a hemianopic defect because it's an intrinsic lesion of the occipital cortex and its projections.
But so suppose somebody has bilateral cortical blindness or top of the basilar and both cortical blindness are gone.
Well, then it's very simple. They are blind.
So how do you...
Bilateral homonymous hemianopia.
No, how do you distinguish this cortical blind from functional?
So, optokinetic nystagmus.
Yes, absolutely. And you can even put a mirror in front of the patient. There are many other tricks. If you put a mirror and move the mirror, the guy follows the mirror, etc.
I don't want to be very naughty. I don't want to be very naughty, but there are various types of evoke responses.
You are live on YouTube, so you better not.
Yeah. There are various types of evoke responses that you can try and elicit.
Okay. Nasli Ichapuri asks, why do you get macular sparing in an occipital lobe lesion? That is
That is the peri-occipital cortex. I showed it on the optic radiation slide.
yes.
It is just anterior to the occipital cortex. You get sparing of the macular vision.
And probably that is supplied by both MCA and PCA, therefore it might get
No,
spared.
occipital lobe is supplied by the PCA. But it is somehow the other, the infarct does not involve the macular fibers.
Okay. I'm just taking a few questions. We can't take all. Okay, Dr. Minal Joshi asks, do IV steroids only hasten recovery or does it change magnitude of recovery, the final one?
Hasten and magnitude. At 3 months interval, there was no statistical difference.
Yes. Dr. Ashok Sirsat says, how often has anyone seen tram cars in the fundus during an ongoing TIA?
Amaurosis fugax?
No, how often is tram car seen in the fundus during ongoing TIA? That
Yeah, segmentation. What he means is segmentation or the passage of a embolus. I think the first description of that was given by Professor Ross Russell at the Queen Square.
Okay.
When he was doing a fundoscopy, he found that the patient, he saw the crystals go, and the patient complained of blindness. They had not dilated the pupil, and he found that the pupil suddenly dilated. He was blind for a few seconds, and then it cleared up. I think that is the only documented example that I have noted from my reading. Subsequently, I don't know.
Okay. Many people have, of course, said it's a great talk. I won't go into that, but Dr. Ganesh Kini has said something very interesting. He said, great, sir, for taking us into 4th floor seminar room of JJ Hospital after so many years. Thank you for the... Okay.
Thank you. Thank you, Ganesh.
How to differentiate optic neuritis from acute pan-retinitis?
Fundus?
Yeah, you will see a
Fundus examination.
retina will. Okay, then.
Whoever has asked that question has not done enough of fundoscopy.
Yes. Somebody is asking, while performing RAPD, do you have to keep a partition between the eyes?
Not necessary. Not necessary. If you do it in a U shape, and if your torch is nice and bright and has a very focused beam.
Can RAPD, there are lots of questions on RAPD. Can RAPD differentiate optic neuritis from AION?
Anterior ischemic optic neuritis? No.
No, it can't. In all optic nerve disorders.
In all optic, up to the junction of the optic nerve with the chiasma.
There is one common fallacy. Many people write bilateral RAPD. So can there be anything like bilateral RAPD?
No.
No, because you are comparing the two.
It can be if you have a asymmetrical
Absolutely. So you
optic nerve pathology. If the left optic nerve is markedly involved and the right is just early, you can get a left RAP.
Yes. There has to be a difference between the two.
Once you have bilateral involvement, you cannot.
If it's symmetrical, you cannot. If it's more on one side, yes.
If it's asymmetrical, yes. But then it's not bilateral.
Yes. So have you tried grading the RAPD by putting those filters, gray filters?
No, I have not.
Ophthalmologists do that. But
I have not. I have not done that. I have not done that. I have done everything at the bedside. This whole lecture is meant for the bedside.
Bedside, yes, sir. Okay, this is an interesting question. Loss of retinal venous pulsations is an early sign of raised ICT. How reliable is it?
Well, if you have done it properly, then it's a reliable indicator. But there are a few caveats. Our Indian patients, out of respect for the doctor, will hold their breath while he's doing a fundoscopy. When they hold their breath, they increase the intrathoracic pressure and the venous pulsations disappear. So one of the caveats is you tell the patient, please breathe normally, but keep your eyes steady.
I
That
used to.
is one. That is one. The second thing is that venous pulsations can be unilateral, appreciated in one eye. It may not be appreciated in both eyes.
I
Okay.
used to press on the eyeball and gradually release pressure and wait for the venous pulsation. Do you do that, or is there any
That
point?
is what was called ophthalmodynamometry. Clinical bedside dynamometry. It was for retinal arterial pressure.
Okay.
It
I
is not for the venous
I
pressure.
used to do that. Press with one eye and then.
I used to use a pencil with that rubber at the tip, you
Okay.
know, and used to press it here in the early days. I
Okay.
think afterwards, once we started getting MRIs and everything else,
Yes.
I think all those tests became relatively redundant.
Okay. Dr. Manasa Pravalika, I think this still people are a little confused about how to distinguish papillitis from papilledema.
Okay, I'll repeat it again. Papillitis is a very severe drop in the acuity of vision, but a very mild swelling of the disc. Okay, if you have that combination, it is papillitis. Papilledema is hardly any drop in the acuity of vision, but a severe swelling of the disc.
Yes, absolutely. Very well put. So, if the main problem is vision loss, it is papillitis. If the main problem is disc swelling, it is papilledema.
If the main problem is visual loss, it is papillitis. If the main problem is headache
Right.
without visual loss, it is papilledema.
Dr. Meshram has an interesting observation. I didn't know this. He writes Oliver Sacks had prosopagnosia.
That's why he wrote the book.
He mistook his wife for a hat.
I don't know.
Yes, Dr. Singhal has written that good talk, Sarosh. Worth reading Oliver Sacks, the man who mistook his wife for a hat. I'm
He
amazed.
has given it to me.
Yeah.
He has given it to me.
Wow.
It's on my read list.
What is the prognosis of NAION, non-arteritic ischemic optic neuropathy?
All ischemic optic prognosis is relatively guarded. If the patient comes to you very early, then they say rubbing the eyeball and trying to increase the pressure and whatnot. It also depends on the pathology or etiopathogenesis. If it is very early and of embolic, and if you treat it, then you may be lucky that they may be having some defects of vision, but not total loss of vision. But by far and large, ischemic optic atrophy of any variety carries a poor prognosis for therapy.
Between the two, I would say NAION is better than arteritic because
Correct.
arteritic can happen. These guys improve a little bit. But temporal
On the other hand, you can treat the arthritic with steroids now.
yes. No, once he gets blind, he's gone. But
It's
if
gone.
you treat it earlier at the first sign, you may prevent blindness. I mean, do you use that disc at risk to distinguish NAION versus arteritic?
No,
See that cup to disc ratio.
no, I
With,
don't do that.
with nowadays, with this, what's that thing called? OCT. it has become very easy. We get the disc to cup ratio and you can use that to distinguish. So earlier
If,
it was difficult
if
to
you
measure fundus.
if you get an ophthalmologist to give you a detailed report on the OCT that he has done.
Yeah. No, we have to
Otherwise, we have to interpret the OCT on our own.
and perimetry ophthalmologists tend to just give a printed report, but luckily my ophthalmologist, I make them give the report. So you have to ping them down.
I think it is essential that the run-of-the-mill ophthalmologists do all these things as a matter of routine.
Okay. Functional blindness, malingering, again, same thing people are asking. I think you've already answered that.
I think it's very important that one does optokinetic nystagmus. And even a few beats of nystagmus gives you the diagnosis.
Okay. So, sir, we'll stop here. Another person, Dr. Rahul, has also said he wants to listen to your talk on DALI and neurology, what Dr. Shirsat was saying. So we'll try to fix that sometime. Thank you.
Okay, we can do that. We can do that. But I can also do pupils now. So as I feel more confident about the Zoom, I think I can do more lectures.
Okay, sir.
Thank you very much. Thank you very much.
Thank you.